All of the technical information in this PowerPoint comes from the Diagnostic and Statistical Manual of Mental Disorders, as published by the American Psychiatric Association in 2013. The latest edition is the 5th edition. I've added my own commentary as it relates to this course. I have highlighted several of the most commonly diagnosed mental health issues that may present in your clinic, office, classroom, or other place of work, and it will vary depending upon the population that you encounter. Something to keep in mind as I go through this PowerPoint is that the DSM is a categorical way to look at mental health issues. It is included here so that if and when a client or a patient comes into your office or clinic or practice and states they have XYZ disorder, you have at least a rudimentary idea of what they are talking about. I'm on the side of depathologizing and destigmatizing mental health issues, and I encourage all of you to seek to find out what may be driving the behavior that has been categorized or compartmentalized into a set of criteria. Expressed behaviors that fit a diagnosis can be looked at as an adaptation to experiences or life events that felt overwhelming, chaotic, and sometimes even life-threatening. Learn about these definitions, diagnosis, and criteria is important, but always keep in the forefront of your mind that you are working with a person that may have had to learn ways to cope in less than ideal circumstances. I ask that you, above all, stay curious about the person, not the condition. This is about anxiety, panic, and obsessive compulsive disorders and phobias. So we'll start out with anxiety. Anxiety disorders differ from the general developmentally normal fear or anxiety. They are excessive or persist beyond appropriate periods. They differ from transient fear or anxiety, often stress-induced, by being persistent, typically longer lasting. So the time frame is about 6 months or more, although the criteria for duration is intended as a general guideline with allowances for some degree of flexibility and is sometimes shorter in duration in children. Presentation is more about fear avoidance. Individuals with anxiety disorder typically overestimate the danger in a situation. Remember, the determination about whether the fear or anxiety is excessive or out of proportion is made by the clinician taking cultural context to all factors into account. Age of onset, generally childhood. Many of the anxiety disorders develop in childhood and tend to persist if left untreated. Each anxiety disorder is diagnosed only when the symptoms are not attributable to the physiologic effects of a substance or medication or to another medical condition, or are not better explained by another mental health disorder. So I'll talk about separation anxiety, which has diagnostic features of separation anxiety include the essential features of excessive fear or anxiety concerning separation from home or attachment figures. Some of the risks and prognostic factors are environmental separation often develops after life stressors, especially of loss in young adults. Other examples of life stress include leaving the parental home, entering into a romantic relationship, and becoming a parent. Parental overprotection and intrusiveness may be associated with separation anxiety disorder. There is a suicide risk, especially when there is the presence of mood disorders and substance use. However, this association is not specific to separation anxiety disorder and is found in several anxiety disorders. When we talk about comorbidity, separation anxiety disorder is highly comorbid with generalized anxiety disorder and specific phobias in adults, also PTSD, panic disorder, social anxiety disorder, agoraphobia, obsessive compulsive disorder, personality disorders, depressive and bipolar disorders, and all of these will be discussed in other PowerPoints. Now, with social anxiety, the diagnostic features of social anxiety disorder is a marked intense fear or anxiety of social situations. The individual may believe they are being scrutinized by others. Diagnosis of this in children must include the fear or anxiety occurring in peer settings and not just during interactions with adults. Individuals with social anxiety disorder they may lack assertiveness, or they may be excessively submissive, or less common, highly controlling of conversations. They may show overly rigid body posture or inadequate eye contact, or speak with an overly soft voice. These individuals may appear to be shy or withdrawn and less open in conversations and disclose little about themselves, particularly in large groups. They may seek employment in jobs that do not require any social contact. Self-medicating with substances is common in social anxiety disorder in adults. However, this may exacerbate symptoms of medical illness, such as an increased tremor, tachycardia, and blushing, which tend to be hallmark physical reactions of social anxiety disorder. The median age of onset of social anxiety disorder in the United States is 13 years, with the majority age of onset being between the ages of 8 and 15. Etiology: onset of social anxiety disorder may follow a stressful or humiliating experience. First onset in adulthood is relatively rare and is more likely to occur after stressful or humiliating events or after life changes that require new social roles. Detection of social anxiety in older adults may be challenging because of several factors. Adults tend to focus on the somatic symptoms, comorbid medical illness, they often have limited insight, and changes to social environment or rules that may impair social functioning, or reticence about describing psychological distress. There may be temperamental, environmental, and genetic or physiologic factors, including traits that are related to fear of being negatively evaluated. There is no indication of increased rates of childhood maltreatment or early onset psychosocial adversity in the development of social anxiety disorder. However, maltreatment during childhood is universally a risk factor for social anxiety disorder. Now, when we talk about culture, some cultures-related diagnostic issues include Taijin Kaiofusho in Japan and Korea. It is characterized by social evaluation concerns that fit the criteria for social anxiety disorder and are associated with the fear that individuals make other people uncomfortable. This may cause them to abstain from social contact. The fear is sometimes experienced with delusional intensity and may also be found in non-Asian settings. Other presentations of Taijin Kaiofusho may fulfill criteria for body dysmorphic disorder and delusional disorders, which will be discussed later. Prevalence rates of social anxiety disorder may not be in line with self-reported social anxiety levels in the same cultures or societies with strong collectivistic orientations. They may report higher levels of social anxiety but low prevalence of social anxiety disorder. Cultural considerations in relation to psychological health and well-being will be discussed in the next module. So some functional consequences. There's several of them related to school dropout, decreased well-being and employment, workplace productivity, socioeconomic status, and overall quality of life. Social anxiety disorder may also be associated with being single and married or divorced, not having children, and the disorder is often comorbid with anxiety disorders like major depressive disorder and substance use disorder. Generalized anxiety. This has the essential feature of excessive anxiety and worry about a number of events or activities. As the name implies, it's nothing specific. The intensity, duration, or frequency of the anxiety and worry is out of proportion to the actual likelihood or impact of the anticipated event. The individual may find it difficult to control the worry and keep worrisome thoughts from interfering with attention to tasks at hand. During the course of the disorder, the focus of worry may shift from one concern to another. In a clinical setting, this can be challenging to deal with since the client or patient seems to jump from one issue to the next with no seeming anchor in reality. Some common features include restlessness or feeling keyed up or on edge, being easily fatigued, having difficulty concentrating or reporting their mind going blank, irritability, muscle tension, and sleep disturbances. oftentimes difficulty falling or staying asleep, or restlessness and unsatisfying sleep. This is indicative of high sympathetic nervous system arousal. Many individuals with generalized anxiety disorder report that they have felt anxious and nervous their entire life. The onset is a broad range with median age later than other anxiety disorders and is reported as 30 years of age. Symptoms tend to be chronic and wax and wane across the lifespan, fluctuating between syndromal and subsyndromal forms of the disorder, with full remission rates being very low. The etiology, there are temperamental, environmental, and genetic, as well as physiologic prognostic factors. And temperamentally, there is behavioral inhibition, negative affectivity, and harm avoidance. Although childhood adversity and parental overprotection has been associated with generalized anxiety disorder, no other environmental factors have been identified. There is no information as to whether the propensity for excessive worry is related to any specific culture. With functionality, the DSM reports that in clinical settings, generalized anxiety disorder is diagnosed somewhat more frequently in female identifying patients than in male identifying patients. There are functional consequences, with excessive worry impairing an individual's capacity to do things quickly and efficiently, whether they are at home or at work. Though worry can take a great deal of time and energy, there are often associated symptoms of muscle tension and, again, feeling keyed up or on edge. The experience of being perpetually tired, difficulty concentrating, sleep disturbances that contribute to the impairment, again related to overactivation of the sympathetic nervous system. Generalized anxiety disorder is associated with significant disability and distress that is independent of comorbid disorders, and most non-institutionalized adults with this disorder are moderately to seriously disabled. Social phobias, fear or anxiety that is related to the presence of a particular situation or object. There's an increase in physiological arousal, often in anticipation of or during exposure to an object or situation. However, the physiologic response is the feared situation or object. It varies. It's truly situational. Natural environment and animal-specific phobias are likely to show sympathetic nervous system arousal. Individuals with blood injection-specific phobias often demonstrate a vasovagal fainting or near fainting response that has an initially brief acceleration of heart rate and elevation of blood pressure, followed by a deceleration of heart rate and a drop in blood pressure. Current neural models for specific phobias emphasize the role the amygdala and related structures have, similar to other anxiety disorders. So the etiology for specific phobias sometimes develop following a traumatic event. Observation of others going through a traumatic event, an unexpected panic attack in the feared situation, or hearing about someone else's experience can elicit the response. Many individuals with specific phobias are unable to recall the exact reason for the onset of the phobia. However, these develop in early childhood, with the majority of cases developing prior to age 10. There are temperamental, environmental, as well as genetic and physiologic factors, which include negative affect or behavioral inhibition. It has also been shown that parental overprotectiveness, parental loss or separation, and physical and sexual abuse can be connected to the development of anxiety disorders. There may be genetic susceptibility to a certain category of specific phobias, but no definitive studies have been conducted. It is important to know that people with specific phobias are up to 60% more likely to make a suicide attempt than are individuals without the diagnosis. It is likely that these elevated rates are primarily due to comorbidity with personality disorders and other anxiety disorders. Some functional consequences include impairment in psychosocial functioning, such as decreased quality of life, as well as higher rates of alcohol and substance use disorders. There may also be issues related to occupational and interpersonal functioning. The distress and impairment caused by specific phobias tend to increase with the number of feared objects and situations. Oftentimes, these specific phobias can get in the way of activities of daily living. For instance, in older adults, a fear of falling may reduce mobility and other physical activities, and for some, the fear of vomiting or choking may reduce dietary and medication intake. Moving on to panic disorders. This refers to recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or discomfort that reaches a peak within minutes and may include one or more of 13 physical and cognitive symptoms listed. The term unexpected refers to a panic attack for which there is no obvious key trigger at the time of the occurrence. The abrupt surge can include one or more of the following listed: palpitations, pounding heart, accelerated heart rate, all of these things, feeling of choking, chest pain, nausea, feeling dizzy, unsteady, chills, paresthesia, tingling sensations, derealization, fear of losing control, fear of dying. The frequency and severity of panic attacks vary widely. There may be moderately frequent attacks, for example, 1 per week for months at a time, or short bursts of more frequent attacks, for example, daily, separated by weeks or months, without any attacks, or with less frequent attacks over many years. Worrying about a panic attack or the consequences of a panic attack usually pertain to physical concerns, such as worry that the panic attack reflects the presence of a life-threatening illness, like having a heart attack, seizure disorder. There are social concerns, such as embarrassment or fear of being judged negatively by others, and concerns about mental functioning or losing control. Oftentimes, the fear of a panic attack is worse than the actual event. If you look at the symptoms list, it is all related to that, again, that high sympathetic activation. The median age of onset for panic disorder in the United States is between 20 and 24 years of age, with a small number of cases beginning in childhood and even fewer with an onset after the age of 45. Temperamentally, there can be negative affectivity and anxiety sensitivity. With etiology, environmentally, reports of childhood experiences of sexual and physical abuse are more common in panic disorder than in certain other anxiety disorders. Smoking is a risk factor. Panic attacks and panic disorders, again, related to smoking. Most individuals report identifiable stressors in the months before their panic attack. Current neural symptom models for panic disorder emphasizes the amygdala, again, and related structures, much as in any other panic disorder. Culturally, let's go to functional first. Respiratory disturbances such as asthma is associated with panic disorder in terms of past history, comorbidity, and family history. Again, feelings of serious health issues like cardiac arrest can create the leveling up of symptoms. Functional consequences of panic disorder include high levels of social, occupational, and physical disability, considerable economic costs, and the highest number of medical visits among all anxiety disorders, although the effects are strongest with the presence of something like agoraphobia. Individuals with panic disorder may be frequently absent from work or school for doctor or emergency room visits, which can have a consequence of job loss and poor school performance. Now, cultural. Some of the culturally related diagnostic issues, for example, in Vietnamese individuals who has a panic attack after walking out into a windy environment may attribute the panic to exposure to wind as a result of linking these two experiences. This is not unusual in practices related to acupuncture or other types of Asian medicine. Various cultural syndromes are associated with panic disorder include attaque des nervios among Latin Americans and Kial or soul loss among Cambodians. Attaque des nervios may involve trembling, uncontrollably, screaming, crying, aggressive or suicidal behavior. And depersonalization or derealization, which may be experienced longer than a few minutes, typical of a regular panic attack. The specific worry about panic attacks and their consequences will vary from one culture to another. Moving on to obsessive compulsive disorder and related disorders. They include OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, excoriation, and obsessive compulsive disorder that's not related to medication or another medical condition. So some characteristics of OCD is the presence of obsessions and or compulsions. So defining obsessions is a recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted, where compulsions are defined as repetitive behaviors or mental acts that are individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The obsessive compulsive and related disorders differ from normal preoccupations and rituals by being excessive or persisting beyond developmentally appropriate periods. Many individuals with OCD have dysfunctional beliefs that there is the tendency to overestimate threat, including perfectionism and intolerance of uncertainty, and may also include overimportance of thoughts and the need to control those thoughts. The specific content of obsessions and compulsions vary between individuals, but there can be certain themes or dimensions which can be common and include those of cleaning, symmetry, repetition, forbidden or taboo thoughts, and can also include fear of harm. Some individuals have difficulty discarding objects, which may rise to the level of hoarding, which will be discussed later. Culturally, these themes occur across different cultures, are relatively consistent over time. Often individuals have symptoms in more than one dimension. Individuals with OCD experience a range of affect in response to being confronted with situations that trigger obsessions and compulsions. There may be a great deal of anxiety that can include recurrent panic attacks. Others report feeling strong feelings of disgust. Some individuals report distressing sense of incompleteness or uneasiness until things look, feel, or sound just right. It is common for individuals with this disorder to avoid people, places, and things that trigger those obsessions or compulsions. As far as age, in the United States, the mean age of onset of OCD is about 19 and a half years, with about 25% of cases starting by the age of 14. Onset after age 35 is unusual. Etiologically, temperamentally, there is greater internalizing symptoms, high negativity, high negative emotionality, and behavioral inhibition in childhood. These are possible risk factors. Physical and sexual abuse in childhood and other stressful or traumatic events have been associated with an increased risk for developing OCD. The rate of OCD among first-degree relatives of adults with OCD is approximately 2 times that among first-degree relatives of those without the disorder. There is evidence of neurologic issues in the orbitofrontal cortex, anterior cingulate cortex, and the striatum. Culturally, diagnostic issues show that around the globe there are similar symptoms, including cleaning, symmetry, hoarding, taboo thoughts, or fear of harm. Cultural factors may shape the content of the obsessions and the compulsions. When we talk about comorbidity, there is the presence of comorbid major depressive disorder. It increases the risk of OCD, and suicidal thoughts occur at some point in as many as about half of the adults with OCD. Functionality. Some functional consequences include reduced quality of life, impairments across many different domains of life, and is associated with symptom severity, which can include time spent obsessing and doing compulsive behaviors. Another way to look at this is through the lens of control and safety. So if you grow up in a chaotic environment or experience disrupted connection or attunement from primary caregivers, it may feel unsafe, but you can kind of control that by performing actions that help to settle your system. Sadly, the behaviors often escalate into severe dysfunction. Body dysmorphia, trichotillomania, and excoriation. Body dysmorphic, individuals with body dysmorphic disorder are preoccupied with one or more perceived defects or flaws in their physical body, which they believe they look ugly, unattractive, abnormal, or deformed. There are subcategories of muscle dysmorphia, which includes preoccupation with the idea that one's body is too small or insufficiently lean or muscular. This is more common among male identifying genders. There is often diet regimens, exercise, and or weightlifting to excess, sometimes causing physical bodily damage and often the potential for dangerous anabolic or androgenic steroid use or some other substances that make the bodies bigger and more muscular. On average, their insight tends to be very poor. Male identifying patients tend to have genital preoccupation, and female identifying are more likely to have comorbid eating disorders. As previously stated, muscle dysmorphia occurs almost exclusively in those that are male identifying. Functionality with psychosocial functioning, this diminishes because of the perceived appearance, therefore overall quality of life are markedly poor. The more severe body dysmorphic disorder symptoms are, the worse their functional and quality of life. It affects their job, academic, any kind of role functioning that they may have. About 20% of youths with body dysmorphic disorder report dropping out of school primarily because of their symptoms. Decreased social activity, relationships, intimacy, which may include avoidance, are very common. A high proportion of adults and adolescents with this disorder eventually become psychiatrically hospitalized. Etiology, so environmental and genetic and physiologic prognostic factors include high rates of childhood neglect and abuse, as well as elevated rates of first-degree relatives of individuals with obsessive compulsive disorder. Again, I may attempt to feel safe by controlling what I eat, how much I exercise, etc. If I grew up in an environment where approval was based on appearance or performance, this may become my primary focus in order to fit in. Culturally related diagnostic issues include multiple similarities across races and cultures, but the cultural values and preferences may influence symptom content. Taijin Kaifusho, included in the traditional Japanese diagnostic system, has a subset similar to body dysmorphia called Shubo Kaifo, means the phobia of a deformed body. There are similar behaviors across genders. The differences are often related to dislike of body areas, types of repetitive behaviors, severity symptoms, suicidality, comorbidity, illness course, and receipt of cosmetic procedures to correct those perceived defects. Trichotillomania and excoriation. So trichotillomania is hair pulling. May occur from any region of the body in which the hair grows, but most commonly include the scalp, eyebrows, and eyelids. Hair pulling may also be preceded or accompanied by various emotional states and may be triggered by feelings of anxiety or boredom. Excoriation or skin picking disorder commonly includes sites of the face, arms, and hands. Individuals pick at healthy skin, at minor skin irregularities, at lesions such as pimples or calluses, or at scabs from previous picking. Individuals with excoriation disorder often spend significant amount of time on their picking behavior, sometimes several hours per day. Skin picking can cause significant distress or impairment in social, occupational, or other important areas of functioning. There can be associated feelings of loss of control, embarrassment, and shame. Similar to trichotillomania, skin picking may also be accompanied by various emotional states triggered by feelings of anxiety or boredom, and may be preceded by an increased sense of tension. There is often a sense of gratification, pleasure, or sense of release when the skin or scab has been picked or hair has been pulled. Now, neither of these conditions is specific to an age, sex, gender, race, or culture. They can and do begin at any age for a variety of reasons. There are certain predisposing conditions that may increase the likelihood of someone engaging in these types of behaviors. Certain substance abuses, such as methamphetamine use or abuse, may increase the likelihood of someone picking at their skin. Hoarding. So the specifier for hoarding disorder is excessive acquisition of stuff. The most frequent form of acquisition is excessive buying, followed by acquisition of free items. Stealing is less common. Individuals with hoarding disorder typically experience distress if they are unable to or are prevented from acquiring items. An essential feature of hoarding disorder is a persistent difficulty discarding or parting with possessions, regardless of their actual value. A common feature of hoarding disorder includes indecisiveness, perfectionism, avoidance, procrastination, difficulty planning and organizing tasks, and distractibility. Occasionally, individuals with hoarding disorder live in unsanitary conditions that may be logical consequence of severely cluttered space or that of related to planning or organizing difficulties. So there's a couple different subcategories. When we talk about animal hoarding, this can be defined as the accumulation of a large number of animals and a failure to provide minimal standards of nutrition, sanitation, and veterinary care, or to act on the deteriorating condition of the animal. Oftentimes, individuals who hoard animals are also hoard inanimate objects, with the primary difference being the extent of unsanitary conditions and poor insight. With age, hoarding appears to begin early in life and spans well into late stages. Symptoms may first emerge around the age of like 11 to 15. Participants in clinical research studies are usually in their 50s, and the severity of hoarding increases with each decade of life. So oftentimes this doesn't even come to people's awareness until the person is older. Risk and prognostic factors include indecisiveness as a prominent feature of individuals with hoarding disorder. They often retrospectively report feeling stressful and traumatic life events preceding the onset of the disorder and causing an exacerbation. The genetic and physiologic factors include familial behaviors that about 50% of individuals who hoard report having a relative who also hoards. So this would make sense in the fact that we learn behaviors from those who influence us the most. Most of the research done on hoarding disorders has been in Western industrialized countries and urban communities. However, the data available from non-Western and developing countries suggests that hoarding is a universal phenomenon with consistent clinical features. Functionality. So there are some obvious functional consequences of hoarding disorder, including clutter that impairs basic activities such as moving through a house, cooking, cleaning, personal hygiene, and even sleep. Consequences can include utilities such as water and electricity having been disconnected or in disrepair due to accessibility issues. In severe cases, hoarding can put individuals at risk for fire, falling, poor sanitation, and other health risks. Family relationships are frequently under great strain. Conflict with neighbors and local authorities is common. The substantial portion of individuals having been involved in legal eviction proceedings and some having a history of eviction. There are often comorbid mood or anxiety disorders, major depressive disorder, and symptoms that meet the criteria for OCD. So if you haven't done so, perhaps watch an episode or two of the various television shows that give a glimpse into what this condition is like for the person. All of these disorders share features of excessive fear and anxiety related behavioral disturbances. The DSM defines fear as the emotional response to a real or perceived imminent threat, and anxiety is defined as the anticipation of future threat. There is the general category of anxiety as well as the specific categories like separation anxiety, social anxiety disorder, generalized anxiety disorder, phobias, and even hoarding.